Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast.
Hi, everyone. Dr. Eric Westman here again, and welcome to my podcast where I review and debunk nutritional misinformation online. Occasionally, I get to talk to movers and shakers in the low-carb, keto, carnivore universe, and it's my great pleasure to talk to Dr. Tro Kalayjian today. Tro, how are you doing?
Thanks for having me on. I'm super excited. It's been great working with you on this new position statement, and just happy to be here.
Yeah, and so we'll get to that in a minute. The type 1 diabetes position statement from the Society of Metabolic Health Practitioners just came out, and it's creating a ripple some ways out there. But before we get to that, imagine you're talking to a group of my patients who don't know who you are, never heard of the Low-Carb MB Podcast, never heard of Dr. Tro and what you've done. Where did you get started, and how did we come to meet?
Sure. My name's Tro Kalayjian. I go by Dr. Tro on social media. I am a board certified internal medicine doctor. I trained in the Yale New Haven hospital system. I was chief resident at Greenwich Hospital in internal medicine. And after I found myself a 350-pound doctor, I was challenged by my wife, my amazing wife, to sort of understand obesity like I understood, all of medicine. And my wife, who knows how to manipulate me quite well, really played on my arrogance, my New York City arrogance. And she said, "You're so smart. You got on the 90th percentile on your board exam. And can you figure out obesity like you know the rest of medicine?" And so that's where my journey started. Over 10 years ago, I was 350 pounds. And so I went to the literature at that time. And lo and behold, I read all of your work. I subsequently read your textbook on obesity and all the studies you did yourself, Yancey, Gardner at the time, the A to Z trial. And I went through systematically the medical literature. I just wanted to know what would help me. And when I turned to the medical literature, I took the approach like this was an antibiotic for pneumonia. I wanted to just see them, head to head, what was the best. And I wanted to go with sort of what was the best. And, as I looked into the interventional data, what I saw was every interventional trial showed one conclusion, but all the guidelines and observations said another conclusion. And so I went with what I thought would help me, which was the interventional data. So I ended up doing a low-carb diet and really relying on Atkins, yourself, Yudkin, Yancey. And that the rest is history. I lost 150 pounds. I became a certified personal trainer. I became a certified health coach. I became obesity medicine certified because I had a new lease on life. My kids got to see me, go from a old, tired, achy 350-pound dad who was barely around because he was overworked, and to a healthy, person who has a new lease on life. And I couldn't practice the same way. I had a number of different reasons why I left sort of traditional and academic medicine and pursued sort of private practice. And I have a nationwide telemedicine practice with myself and Dr. Laura Buchanan and a PA. And we have 4 health coaches, all who've lost weight. Our team has lost 700 pounds. Our 4 health coaches, our personal trainer, and we provide comprehensive sort of nationwide care with more of a focus on employers. We go directly to the employer. We tell them, look, we have a track record of, here's our results in people who are overweight or have metabolic syndrome, and here's how much money we save from the prescriptions that are no longer needed. And so our focus over the last 2 years has really been, adding 7th, 8th, 9th employer now. So that's, I started 7 years ago with the Low-Carb MB podcast, of which you've been on twice or 3 times, which we've been grateful for. And, we've had the pleasure of working together, I think, on 3 or 4 papers now. And your leadership and guidance has really meant a lot to me. So I just have to say it. I thank you for everything you've done.
Well,
I thank you for doing what you're doing.
You're welcome. And I'm just passing along a baton, on this relay race. So when you started, it's fascinating. Did you get nutrition training at all in practice or in medical school, undergrad? What was your undergrad degree in?
Yeah. So I had an undergraduate degree in health science, where nutrition was one of my courses. I went to an osteopathic medical school, which has a, more of an emphasis on both diet and manipulation and exercise. There's a bit of more of emphasis on that and anatomy as well. I trained in an allopathic internal medicine residency program in the Yale system. And so I've sort of experienced all the different worlds. And I look back and it was basically vitamin deficiency. That was it. That was the extent of it. There was no medical nutrition therapy that was not taught in any systematic way. And I had to learn that on my own. It wasn't even taught in obesity medicine certification, right? So which is, as as being a prior president of the OMA, it's basically soups and shakes and drugs. So it's all self-taught.
Well, in internal medicine, even to this day, I'm in the internal medicine division that teaches at Duke, and we basically teach medication care. And I'll joke with my patient as I've had them write out what they eat over the course of a day. Has any other doctor ever asked you what you eat, over the course of the day? And usually they're like, no, they just say, what kind of diet am I following? And just eat less and exercise more. So, and then when you really got started in this, it was a family member who kind of challenged you to learn about this, not your workplace, not doctors or patients. That's great. It was 2 of my patients that got me to learn about this as they lost weight in front of me. So it's great that you went to the literature kind of looking for what was best. And, by that time, there were a dozen studies of low-carb diets, ours being 1 or 2 of them. And they all beat out a low-fat diet. And nobody knows what a Mediterranean diet is. So with that, getting to internal medicine now, the treatment that both of us do with our patients, it's really pretty remarkable, isn't it?
I can tell you, I went through training and 10 years as an attending, and it was only basically when I emphasize nutrition and lifestyle that I see any disease improve or reverse. I mean, full stop. Never saw diabetes reverse, only saw it progress. Never saw hypertension reverse, only saw it progress. And never saw obesity reverse. I only seen it progress. And same, unfortunately, same with alcoholism and, other, cancer. I mean, it's just the psychiatric illness, the list goes on. And it's really disheartening being a doctor and wanting to go into a profession of actually healing and then never doing it.
Well, we were managing people with medicines. Isn't that fun? No, it's not fun. So,
No.
But a lot of doctors, friends in my area, they just kind of get used to that, of not fixing anything. And I don't know. I think there's a lack of awareness among doctors that you can reverse diabetes, hypertension, all these other problems, obesity, of course, by lifestyle change, right? Is that your experience, that other doctors just don't know about it?
I think not only did I not know, they're apprehensive. Like it's as if, something shifty is going on, which I fully, I'm happy that they are, skeptical. And that's why I think you published what you published. And that's why I've always published, we do case series of our results and case reports and retrospective analyses just to show people what we do, so they can see it in the peer-reviewed literature and not have to trust me for it. So that's been my passion.
And yet there's a failure, I think, of belief of the literature even. Some people are skeptical of the drug companies and their papers. So, but to have the daily reversal of diseases that we have, it's actually pretty amazing to me that it's sort of been underappreciated. I'm really glad, and there is a pressure point for companies that are self-insured in particular, because they can do things outside other insurance systems, and then they save the money if they spend less on it. So it occurred to me some time ago that health insurance doesn't really care if we help out. That's kind of odd, but they don't mind just managing the diabetic, and I mean, building more dialysis centers and all that. But a self-insured company, well, and the individual themselves should mind, right? Now, tell me some pearls from the Low-Carb MD podcast, because you're talking to doctors, you're talking to patients, you're getting a lot of feedback there. And what have you noticed changing from the podcast?
Yeah. So the podcast is run for 6 years now. And yeah, over 6 years, we're in our 7th year, over 10 million downloads. And I've had the opportunity to, interview over 350 amazing people. About half of them are doctors. The other, a third are doctors, a third are scientists or sort of advocates. And then a third are patients with remarkable stories or challenging stories or having difficulty. And it's been absolutely fantastic to be able to network, meet people, share some pearls like you do with this Adapt podcast. It's been really great to be able to sort of reach out and reach people. We've never, and the podcast taken it, and there's no commercials. We have no commercials. We've never accepted any sponsors or commercial interests. It's 100% funded by the listener. And so, at least the listener can know that it's not sponsored by a electrolyte company or vitamin or supplement company or a green shake company or anything like that. They're getting, unfiltered, uncompromised sort of input. It's been great. It's been awesome.
Well, I have this vague memory of one of the first times we met at a meeting, and I not being into the internet podcast world was kind of skeptical and thought, who is this Dr. Tro putting himself on the podcast and the low-carb MB? But I'm so impressed with what you've done, and if I apologize for any early I should have been just totally supportive, but I was, apprehensive about internet podcasts and all. And it was only after watching low-carb diabetes.co.uk be online for, a decade without harming people with diabetes, talking about low carb. That's my concern, right? Is that we will teach someone and they're on way too much medicine and they're not taught how to get off the medicine, the de-prescribing so quickly. But anyway, now that I think it's really helped that we as practitioners are all coalescing together in various places, one being the Society of Metabolic Health Practitioners. And that's the guideline that just came out. And thank you so much for putting together the type 1 diabetes consensus statement or guideline statement. It's published in the Journal of Metabolic Health. And you can actually go to the Journal of Metabolic.com and look it up right there. Tell me how the type 1 diabetes consensus statement came about from the SMHP.
Yeah, so this was Adele Height, who both of us know. This was her dream, was to create a metabolic health consortium and really start to make guidelines and disease specific guidelines. Her and Sarah Hallberg, who I know you knew both of them very well, who are the late Hallberg and Adele Height doctors. Both of them are doctors, and this was their dream. So, when we came together to form the Society of Metabolic Health Practitioners, which all of you listeners should go visit their website, smhp.org, the Society of Metabolic Health Practitioners. Look them up, go visit them, consider a donation. It's a not-for-profit. And what we do is we educate doctors, we bring doctors together. We have a sister journal, the Journal of Metabolic Health. And the idea is to unite the metabolic health movement and to start to work together to do projects like what we just did, like Adele had envisioned and like Dr. Sarah Hallberg had envisioned. So if you're a health coach out there, a personal trainer, an average person who just wants to be an accredited metabolic health practitioner, you can go and become accredited, which I think is really cool. If you want to start helping people and gain some certification. So that's the Society of Metabolic Health Practitioners. You and I have been on the board now for a number of years, over 5 years, and along with so many other people. And the type 1 consensus statement came together when we got a lot of interest around type 1. And this happened pretty much a year ago at the Boca conference. Again, if you're a listener, we had an amazing conference in Boca, which everybody should go to on type 1. And when we were advertising this type 1 focused conference about a year ago, we got a lot of interest in working together and starting a project like this together. So a lot of amazing people came together. Yourself as the senior author, Dr. Laura Buchanan, Ian Lake, a doctor with type 1 from the UK, Evelyn Bourdois-Roy, a Canadian doctor, David Dykman, who's, you've written a paper with and who's been on your podcast and been on Adapt, Dr. Robert Sybis and Mark Cucuzella, Matt Calkins, Beth McNally, all these people, came together, particularly after the conference, and we finally got together some consensus at that conference of what was needed and where the gaps were. So this conference from the SMHP really brought the docs together. We really knew the gaps that we needed to address. And for the average listener who knows nothing about type 1, this is what you have to know. Type 1 is an autoimmune disease where the body attacks the pancreas most commonly. And the pancreas, what happens is the beta cells, those cells that make insulin that help us regulate our blood sugar, those start to die off. There's some antibodies you can test to test for it, but oftentimes this presents like a flu, or you end up in the hospital dehydrated and you see that your blood sugar is 400. And then ultimately you may find out that you have type 1 diabetes. Now, unlike type 2 diabetes, which now more recently with the help of Dr. Yancey, your colleague there in North, in Duke, type 2 has clear recommendations that a low-carb diet works and is effective, even though the ADA, also says 3 other diets that are high in carb work. They, out of one side of their mouth, they say low carb works. At the other side of the mouth, they say, actually, you should eat high carbs. So it's confusing. But in type 1, there is no recommendation for a specific diet. So the problem that happens is endocrinologists, pediatricians, dietitians default to the USDA recommendations, which are high in carbohydrate. And so, what's happened is these patients are forced into a higher carbohydrate diet by default. Okay, that's one issue. And the second issue is their health outcomes have been disastrous. people with type 1 diabetes die 20 years younger than the average person. And if you're in a country, a third world country, or a country that's maybe not as much access to medicine as the United States or some European countries, right, you could die 40 years younger than you should. And the damage from high blood sugar is devastating to the eyes, where you can experience blindness, to the kidneys, where you can experience renal failure, and to the nerves, where you can lose feeling in your limbs, and maybe even resulting in an amputation. So, and the rates of these are tenfold higher. I mean, it is truly terrible. And in the United States, where we should have the most amazing outcomes in these patients, where now we have, insulin pumps and closed loop systems, and we have availability of insulin, the average A1C is 8, which is, almost 3 standard deviations out from normal, right? So this is a huge problem because our current approach is producing disastrous results. And that A1C of 8, what it means is a patient with type 1 is going to die young. They're going to experience blindness. I mean, not to mention the amount of comorbidities that are associated with type 1 that often go unrecognized: anxiety, depression, constant fear of blood sugar that's going up and down. I mean, it is a truly terrible life. And to be told by your dietitian when you want to go on a low-carb diet that that's an eating disorder or it's inappropriate because you have type 1 is a crime. And so that's the passion with which this consensus statement came from.
Yeah, and well, and the science is so solid here, right? Diabetes is, even type 1 diabetes is a problem of excessive blood sugar, glucose. So you'd think it would make sense to lower the glucose and the sugar in the foods, and especially in type 1. And I learned this first through Dr. Bernstein, who has the book, The Diabetes Solution, and has been practicing out of his office on the Mamaroneck Sound, or the Long Island Sound in Mamaroneck, New York. I visited him 20 years ago. And just a couple of years ago, I went back. He was still at his same desk in his same house, and he just turned 90. Type 1 diabetes himself, wrote a book, developed a following. Some followers helped him get his information into Facebook and into the internet. And we surveyed the followers of Dr. Bernstein and published that paper. And Belinda Lennertz and David Ludwig at Harvard got it into the Journal of Pediatrics, where it was the most cited paper for that year. And I remember the rebuttal article. This was a survey of Facebook folks following low-carb diets with type 1 diabetes, and their A1Cs were normal. And on average, they were using 25 units of insulin a day. And the rebuttal to it was that, well, this isn't, normal. These are aberrant people who are, superhumans, and, mere mortals can't do this and use medicines so the powers that be, again, in the pediatric world for type 1 is medication focused. And yet the parents, so the pre-course at the Boca meeting, this is Boca Raton, Florida. Once a year, the SMMHP has a meeting there on the East Coast, and then San Diego on the West Coast. The parents were telling me that they go into their pediatrician with normal blood sugars and with a hemoglobin A1C that's low, and the doctors suspect them of mistreatment because nobody has that low a blood sugar. And they suspect that the average, the A1C, means some of them they're having hypos to balance the hypers. And when they show them the glucose monitors like this, the doctors freak out. I don't get it. Except I do remember 20 years ago when I started with this, I wonder how long it took you to get used to the fact that some people have an elevation in cholesterol. And now we're learning that it's probably not as bad as everyone, well, I know it's not as bad as everyone said it was going to be, but I remember treating someone with type 1, a young man, and I was worried that his LDL cholesterol went up. And I wonder if that's even one of those guardrails that make make pediatricians not consider low carb diets. Of course, not everyone has that sort of cholesterol elevation, but hearing these parents say that they're often told by the doctor to, stop what you're doing because the blood sugars are too good. It's kind of crazy.
Yeah, I think you hit the nail on everything that matters. The you know the position statement outlines all of the literature basically to date that supports a low carbohydrate approach in type 1. That doesn't mean there aren't questions remaining and more research doesn't have to be done. But this group that included, patient advocates, that included patients with type 1 diabetes, family medicine doctors who deal with everybody from pediatrics to OB to, and including internal medicine docs from other countries, including Canada and the UK, and included researchers from South Africa and all the way to Montana, right? So I think when we started this position statement, it was let's get metabolic health oriented doctors and a group together to figure out what we agree on. And the decision that the outcomes were unanimous. You were on those emails and those meetings where we sort of surveyed us, and it's that low carb diets should not be withheld, and they should not be withheld. And in fact, every single endocrinologist, every single pediatrician, every single dietitian needs to offer it as a option in relation to the current status quo, which is largely unacceptable. And that doesn't mean that there aren't issues that may arise, and that doesn't mean that more studies don't have to be done. But there is no evidence to suggest the current diet is the ideal diet. And so, in the absence of any evidence to suggest the current diet is the ideal diet, we should fall back to the best evidence available. And the best evidence available suggests that a low carbohydrate diet is absolutely feasible and safe and has the best potential in the literature. And it could be that everybody can't do it, and that's fine. And those people can eat, and the way that they feel most comfortable. And their clinical teams or medical teams, they can use the current, carb counting approach if they want. But in addition, they should be offered a low carbohydrate approach. And it was hard to get, 15 people to agree. But I think we agreed on most things, and the statement is pretty strong. And hopefully we can raise some money to do research so we can go to the docs. And there's already research. There's already head-to-head studies saying, low carb diets will improve the time in range, which is that time between where the blood sugar remains between 70 and 180. And normal range is a blood sugar of 70 to 120. We have the evidence to say it'll improve the time in range, and it'll be great to add to that body of literature with other studies so that we can say it doesn't, cause hypoglycemia. There's no evidence of that, but we can firmly say that. And we'd like to be able to say, it doesn't increase the risk of DKA. Again, there's no evidence for that, but we can tease these out in the literature, hopefully.
Yeah, well, I did a paper with David Dykman, who's one of the authors of the survey and helped with Dr. Bernstein. And we basically did a power calculation, meaning how many people would have to be in a study to show that the low carb diet has better A1C control than the standard American diet. And it was like 50 people. It was very similar to the study we did on type 2 diabetes compared to a low glycemic, keto versus low glycemic. You don't need many people to show a benefit. So if I could, with a magic wand, dream and carry out a study, it would be randomizing people with type 1 diabetes to a low carb diet or the recommended diet. You look at insulin, you look at time and range, you look at hypos, you look at patient satisfaction. What I learned from the parents is that they're really kind of deathly scared that their children will have low blood sugars in the middle of the night. If you don't have type 1 diabetes or don't know anyone with it, if the children have a very low blood sugar at night, it can be really, it could be lethal. It could be very harmful at a minimum. So actually some of these parents are measuring the children's blood sugars at night with the glucometers now. You don't have to wake them up to prick them with the finger prick blood sugars. And so what I experienced was the parents saying that they're relieved now that their children don't have these hypos at night, which happens from all of the carbs going in and all the insulin that's being given, which was one of Dr. Bernstein's teachings from, a long time ago. So the parents really helped me understand I kind of knew the complexities of the problem, but many people come into this, don't know what to do, and they look to their doctor for, kind of almost like religious advice. So if the doctors aren't saying low carb is okay, they won't do it, right? I mean, they're under the fear of this disease. The Deichmann family wrote a course to teach people, teach parents how to do this, and I watched the course, and at first they were told the exact opposite. They were told that David could have pancakes and sugar all day long, and it was actually Dave that came up with the idea that, hey, why don't I just don't eat sugar, and the blood sugars then went like this. So the confusion from the medical world, as I looked over the consensus statement, we don't have a pediatrician on it. I didn't really hit me until recently, but that kind of makes sense, because the mainstream pediatric way, paradigm doesn't really include the low carb diet, does it?
Well, that was the paper before that we wrote together in the Journal of Metabolic Health, criticizing their consensus statement, the AAP's consensus statement. So the AAP has gotten under a lot of scrutiny lately. You may have seen them in the news for a number of comical hearings that have happened with their executive and lead committees. They put out a consensus statement in 2023, late 2023, saying low carb diets need 20 labs and an imaging study to be done safely. But you know what? If you want to do bariatric surgery in 13-year-olds, go right ahead. And that's just me exaggerating, but it's not far from the truth.
That's the AAP is the Academy of Pediatrics.
Correct. Yes. Yeah. So when you look at the people who write the guidelines for low carb diets, these are people who took over $200,000 of money from pharma and who really have no experience with metabolic health. I've certainly never seen them lecture on metabolic health. So the authors of that consensus statement, I just wonder if they have any, and certainly they omitted several important studies, and they focused on some very weird sort of literature bodies. So the problem is you're absolutely right. If you're a patient out there right now and you're listening to this and you have a family member with type 1, they will be told to eat Oreos and dose insulin. And what that means, just so you guys know, it's not that I'm trying to take anybody's Oreos away. I'm not. But what happens is they live in fear. Their blood sugar goes up and they have to dose a lot of insulin, and they're living in this fear because their blood sugar is going to come crashing down. Maybe when they're asleep, they're afraid. The families are afraid. The parents are afraid that their kid is going to die at night. And they're also afraid of getting really ill. It does not feel good to go into hypoglycemic shock. So there is a lot of stress around this because the doctors don't know enough to say, gosh, if you really want a cookie, try making it with almond flour and some sweetener, right? It's not hard to do. This is accessible. People can do it. And in fact, we have a great endocrinologist, Dr. Mariella Glant, who's done it in people with SNAP benefits in the Bronx, right? So this is accessible. It's achievable. Any socioeconomic group can put this into play, and it stabilizes blood sugars, and the quality of life seems to go up enough so that every single patient with type 1, they deserve to be offered this as a solution. And you're absolutely right. Just to put together all the studies that are in support of this, I mean, it was a monstrous learning experience for me. And to getting these groups together, talking to them over Zoom, coming to, taking down notes, taking a draft of a paper, going over it, several iterations over several months, coming together, re-editing it, sending out surveys to the whole team of doctors and advocates and scientists, and, coming to a consensus, going to the reviewers, asking the reviewers to rip it apart, and them ripping apart, coming back, redoing surveys, and going on a consensus in an organized way. That's called the Delphi methodology, which is how consensus is reached in the medical literature. Well, this was an enormous project. Took countless hours. And I'm happy that you guided me throughout that entire time. And this is a huge, I can't tell you the outpouring that's happened. If you're listening to this and you have a family member with type 1, go to the Journal of Metabolic Health, go to the, SMHP, the Society of Metabolic Health Practitioners, and go download, this paper and give it to that family member with type 1 and say, hey, you have help now. You have, a team of doctors and scientists that say your doctor should support you in this way if you choose. And there's another amazing group that I'm not a part of, but I have to, comment on because they did an amazing job as well on World Diabetes Day, IPTN up in Canada, our sister group to us up in Canada, with the help of Beth McNally, Francisca Springler, and Andrew Kutnick and Caroline Roberts. They put together an amazing how-to, which I hope we can include in the links to this, so that the people who are out there with type 1 have both of these resources from the SMHP and the Journal of Metabolic Health, the position statement, and then this how-to for your dietitian and doctor, spelling out exactly how to help you do this diet. So these are two amazing resources. I mean, the outpouring, Eric, if you heard it, because I'm the corresponding author, so you've been spared of all the emails, but the emails, they're so thankful. I'm a patient with type 1. I've lived with type 1 for so long. Thank you for doing this. My kids, thank you. We needed this. I mean, it has been, Eric, I cannot tell you the feedback I've gotten. It's been so appreciated by that type 1 community, which has really been ignored.
Well, I hope also some young investigator in the academic world who wants to get started and do something that's kind of a slam dunk. In fact, one of my colleagues said I was shooting fish in a barrel when I did my first study because I visited Dr. Atkins, learned what he did, and then studied published papers based on that. But the shooting fish in a barrel meaning it's not hard. So I mean, it's a slam dunk to beat out the other diets with a low carb diet when you're treating any sort of diabetes, including type 1 diabetes. And now you have the roadmap, you have the literature review from the Journal of Metabolic Health, and then the actual research protocol and the IPTN manual of how to take the medicines down, that sort of thing. And what's kind of crazy is the grassroots world, we're already doing this, right? And yet to get the academic, the mainstream pediatricians and pediatric endocrinologists on board, you need to get those studies done through the system. And I think that's going to happen. It's just, it takes so long for that to happen. So, I'm getting people talking to me now with something that we've been doing for 15 years, but now they're doing it in a study form, thinking that it's something new, like the fatty liver thing where there are new drugs for fatty liver. No. Low carb fixes fatty liver, right? So all these things that we've been able to fix. But the thing that needs to happen is funding needs to become available for this. And yet the catch-22 there is you don't get funded unless you send in a grant that requests funding. Now, sometimes an organization would send out an RFA. That would be, so let's say you're watching this and you're in charge of an organization's research portfolio, send out an RFA that says we need to study low-carb diets and type 1 diabetes. But now if you're an individual, you can do this without waiting, but you want to approach it with someone who has experience doing it. The parents have created organizations at Facebook groups and teaching classes to help out. And I'll put down as many of these resources as I can in the description below.
Yeah, I mean, my hope is that we can bring some attention to the SMHP and to all the grassroots organizations out there that want to embrace metabolic health, that they know what we can do. We want to continue to advocate. We want to advocate for, those with food addiction. We want to advocate for those with type 2 diabetes. We want to advocate for those with hypertriglyceridemia who are told not to do a low-carb diet. We want to do a lot of advocacy and we need support. So if we're not going to be able to do this alone, and at least at this level, and there's so many other levels to go to. And like you said, the research that needs to be done, the hope is that we can actually continue to do this sort of advocacy that's needed in the literature, and then hopefully also in the research realm. So I'm excited. I'm happy for the type 1 community. I'm happy to get this project out. I'm happy that you're, offered to bring me on here and talk about it. And I'm happy for every type 1 patient with type 1, or, maybe you're severe type 2 where your diagnosis is type 1, whatever it is. Now you have a, position statement in the medical literature, so when you go to your doctor and you say, well, I had a hospitalization due to hypoglycemia because of the high carb counting, insulin bolusing strategy you recommended, why didn't you offer me this? Well, now it's in the literature, and I think we've, evangelized a huge community to advocate for themselves with nutrition.
Well, thank you so much for your heavy lifting on this and pushing it forward. Before you go, I have a stump the doctor question for you. So a patient came to me and she had anemia for 7 years. No one could figure out what it was. She, in fact, went to hematologists. They said she wasn't making iron. They would give her iron infusions. She couldn't absorb iron. And we often, go to GI doctors, make sure the GI tract is fine, make sure there's no cancers, things like that, no bleeding, that sort of thing. She went on a carnivore diet. She tells me this story. And in 2 weeks, it was fixed. 7 years of iron deficiency anemia and a carnivore diet fixed it. So what's your diagnosis?
I know the answer. So the first diagnosis I had, it's celiac, right? Well, you know what the diagnosis is? A really crappy medical system.
No, it was the best medical care you can get. No, it was missed. Gluten enteropathy or celiac. And remember, the garden variety workups don't always include a duodenal biopsy, right? So it was a lack of, the person should have gone up the tertiary care ladder a little bit, right? For the diagnosis, but how could a carnivore diet fix gluten enteropathy?
There is, it doesn't have gluten. Of course, it's an elimination diet.
Gluten-free diet.
I would say the one thing, and excuse me for being such a rough New York City doctor, but I'm sorry, that's a failure at the highest level. Okay, I don't know what institution this is. I'm not trying to knock, but
matter.
this is a failure of doctors to listen and think critically and to think differently and to, I mean, any malnutrition, you can't just chalk up every iron deficiency, to hopefully, I mean, I would feel a little better if she menstruated regularly, right? Oh, so that's even, so this is like a huge miss. This is,
I know.
get me started,
And yet it wasn't, but it's just an example of how a low carb or a carnivore diet, it's a gluten-free diet. It's a sugar-free diet. So FODMAP, the diseases associated with that, and it's a artificial sweetener, artificial dye, preservative-free diet, depending how you do it. So it's really an elimination diet of so many possible offenders that, you got it right off the bat. I didn't have to give you, but then you're a former chief resident and me too, where we would come up with cases to try to stump other people. So
I got a case for you then before we leave. Okay. And if you read the paper I sent you that I published, then you'll get the answer. So I'm going to catch you twice. Okay. Well, I won't give you you'll get this. I know you'll get this. I had a 30-year-old patient come to me, okay, with amazing weight loss with a low-carb diet, but persistently elevated blood pressure. And he still had some signs of insulin resistance, including stretch marks on his abdomen. And he showed me his weight loss during our first visit. He had documentation from his hospitalization due to hypertensive emergency on 3 medications, 3 blood pressure medications, which he shared with me. And during that hospitalization, he had a fairly robust workup and was told to go on a low salt diet and to lose weight. Okay. He was discharged with no answers, followed up with a cardiologist with no answers, and followed up with his primary who said, count your calories and keep up your weight loss and stick to your medications for blood pressure management. In my office, now down 30 pounds, his blood pressure was 200 over 100. On exam,
that's really high.
His abdomen had purple markings, and he shared with me, he was so adamant, he's like, Doc, can I share with you? I posted on all social media all the carnivore meals that I've had. And he showed me all his carnivore meals on his social media account. And there was an old pic of him. And despite being 30 pounds heavier 2 years prior, his jawline was much more clear. And his face was very round compared to that picture, despite the weight loss. So what is your diagnosis, doctor?
Well, you're going down into the metabolic problems that we all learned in residency. And did he have a elevated blood glucose?
Oh, he did have an elevated morning blood glucose.
And did he have a buffalo hump?
He did have a bit of a fat pad on the back of his neck. Yeah.
Yeah. Did the hand shake kind of grasp your hand? It was really big or did his hat size?
Oh no, that didn't happen. No, good thought.
Well, I'd be very interested to do cortisol testing, right? To see if this was Cushing's.
So his cortisol came back. His
that dropped. I'm sorry. His cortisol came back
wildly elevated.
Mildly elevated.
No, wildly.
Wildly. Okay. I tell you, let's start this one over. We glitched right when you said
yeah.
So So I would be very interested in his cortisol level. Does he have Cushing's?
He absolutely has Cushing's. His cortisol level was wildly elevated.
Well, this is a good point that if you're, uh, complicated, you have medical issues or things aren't going as expected, see a doctor. We're giving mixed messages, Tro.
Yeah.
And many times we're saying, don't see the doctor, but no, see the doctor. In this case, although was it primary or secondary, or was there an outcome that helped with the hypertension?
Yeah, so I'll send you the paper. And despite seeing a cardiologist and his primary several times and a hospitalization, the diagnosis was missed. It was made by a chance finding that his face was bigger in my office.
Oh, so the
Despite losing
moon faces.
Yeah, despite losing weight. And it was just because I had the time to look through his social media and compare his picture when he was heavier, which had a straight face. And it turned out when we looked to see if his cortisol was high, just because he was stressed out, or if it was due to a problem, we gave him steroids to see if his cortisol would suppress, and it didn't. The adrenal glands should stop making the stress hormones if you give him a bit of steroids, and it was high. And then we found out that he had a brain tumor.
Yeah.
That was causing, we did a test to make sure that tumor we found in his brain was producing the hormone that would make more stress hormones in him. And he went and got the tumor removed through a procedure in his nose. And he is off the 3 medications now, and he is doing fantastic. And he's doing great.
I have to say, I've say in my defense of the case is that
Well, you have the right diagnosis, so.
Well, yeah, but the purple striae on the abdomen are often kind of non-specific, even though we say that's common with Cushing's. I see a lot of people, and I'm sure you do, who do have some stretch marks, and they don't have Cushing's. So so don't worry now. Everyone's going to go home and look for their stretch marks, but I think the telltale sign here, or what's different than what I normally see, is that really high blood pressure. Yeah, in fact, I was thinking back to renal aldosterone stenosis. Yeah, that coarctation of the aorta. I think we always need to think about.
Yeah, those were ruled out, thankfully, in the hospital, where they told him to reduce his salt and lose weight.
The last one was the pheochromocytoma, right? If you had
correct.
Up and down, and even hot flashes, that sort of things. That what a great stump the professor case. Although you gave me an easy one.
Yeah, that was an easy one, but no, of course you'd get it. I knew you'd get it.
Well, but have you done this on the Low-Carb MB podcast, where you have cases, and the world is really interesting. There's a Curbsiders podcast that young doctors listen to. And my nephew, who is a young doctor internist, actually heard Dr. Yancey, my colleague, on Curbsiders be interviewed. And suddenly my nephew was like, "Hey, Eric, Uncle Eric, Dr. Yancey's on." And then, a minute later, he said, "Okay, he mentioned your name." So we have to get this information out. And the powerful effects of nutrition and lifestyle, I'm afraid, just isn't represented in our medical education, is it?
No. And the beauty of this was this particular case, and I loved the Curbsiders, and Yancey is a hero of mine along with yourself, but it was the power of nutrition because the keto was able to mitigate the symptoms of Cushing. Some of the symptoms, his blood sugar was not elevated. He had lost weight. I mean, he couldn't out diet a brain tumor, but so many of his symptoms were actually masked. So I thought the case was very interesting. I'll send you the case report.
A related Cushing's story, a patient of mine finally, because of the high blood glucoses, resorted to low-carb shakes and low-carb eating in order to keep the blood glucoses down while he was getting worked up and had a pituitary adenoma, that brain tumor thing that it pretty much surgically fixes the problem for most people. So that's great. And, we practice the best medicine of our lives without medications, don't we?
Well, let me tell you, the diet, and if you look in the literature, just I know this is getting off on a tangent, but what a great case to exemplify the power of nutrition. Certainly, nutrition can't cure our brain surgery. It can't cure brain cancer, which ultimately this patient needed, but it's still so powerful. It's powerful in patients with Cushing. It's powerful in patients with celiac, like your patient. And it's powerful and absolutely, my heart goes out to those type 1 patients out there who, unfortunately, for decades have been told to, eat carbs, count carbs, dose insulin. And so, as you and I, we work on boards together and we're looking to expand the literature. I hope that we sort of can use the medical literature in a way where others can push the status quo and the convention to sort of think differently. And I don't want to say weaponize the literature, but I'd like to continue to weaponize the literature a little bit.
Use the literature. And yeah, it's important if you're not a physician or a healthcare practitioner. We often are asked, what guideline are you following? Or is there a guideline supporting this? And now there's a guideline supporting low-carb diets for type 1 diabetes from the Society of Metabolic Health Practitioners. I think it's going to be very impactful. Way to go.
I hope so. Thank you.
Until the next time, thanks for your time. Bye-bye. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.